Welcome back to the Pastore podcast. This week is an Ask Dr. Pastore gut health and digestion episode. And this originates because last week I did a gut health and digestion talk with my personal fitness team, and they had a lot of follow-up questions where I was kind of knowledgeable of the answer, but not 100%. So I wanted to go straight to the knowledgeable source and ask him. So to my Hammer Fitness and Lady the F Up team, this episode is dedicated to you. Hope you guys learn a lot. So let's just get into the questions. So in this talk, I covered food intolerances, I covered allergies, I covered celiac disease, artificial sweeteners, the gut microbiome, probiotics, prebiotics, and they had a couple questions. So the first one here is, can you have constipation and bad smelling gas without the other symptoms of a food intolerance, and that's your only symptoms that you have a food intolerance, or is that something else that is off?
Definitely something else that is off. So while those are symptoms that can present in a food intolerance, and they definitely are classified as symptoms for someone that has probably one of the most well-known true intolerances, which is lactose intolerance, and we did a whole podcast on that, those are included as those symptoms. But what's interesting is those symptoms are also associated with some other gastrointestinal conditions. One of which is gaining in popularity, which I'm very happy to hear about. I remember reading the first book by a doctor named Dr. Mark Pimentel. He's a gastroenterologist in California, and I read his book, it had to be about 15 years ago. And it was called the IBS solution, the Irritable Bowel Syndrome solution. And the whole book was on small intestinal bacterial overgrowth, better known as the acronym SIBO. So some people can have some bacterial overgrowth in different parts of their gastrointestinal tract that are not good guys. They're not the good bacteria. They're not the probiotic. And they can cause fermentation of what the individual is eating and of their own byproducts, resulting in these types of symptoms. So it is definitely something that's interesting. If the person is really explaining to you that these symptoms are active, I would definitely encourage them to see a gastroenterologist that's knowledgeable in SIBO. And be examined for that. It's a very easy, non-invasive breath test where you see if you're producing various gases that are associated with bacterial species. I will go for the record, this is me. I'm really nuts in how deep I go. I actually run a DNA map of the entire microbiota of the gastrointestinal tract. So that's a very easy way for me to say, not only do you got SIBO, this is exactly where you got this, or this bacteria is too much, or there's not enough of that species. So I'm a firm believer in DNA stool analysis, but a very easy, cost-effective way is seeing a gastroenterologist and getting a proper SIBO test. That's just the most basic thing. If there are actual true symptoms, I just want whoever's question this is to understand that if they're sick, in addition to having those types of symptoms where they have gastrointestinal discomfort, they feel like they're not digesting, they should of course seek a doctor's help, because there's a pretty good chance there could be something else involved. And I won't get into that because I don't want to take anyone down a rabbit hole and make them think they have a condition like an inflammatory bowel disease, but I don't want to ignore that either, right? If the person is just experiencing exactly what you stated in the question, I would definitely pursue a SIBO path first.
And you mentioned in that answer fermentation, which ties into this question pretty well, because I was discussing broccoli and cauliflower and how they have raffinose and how humans don't have the digestive enzyme for that. So this question is, some leafy greens and cabbage cause bloating and gas. No other symptoms, but how can I tell if this is an intolerance or not?
Yeah, and I mean, there's several ways you can figure that out. There's a lot of people that I can eat. My wife made a raw broccoli salad, and I'm a fan of cooking things, but I like mix of cooked and raw. And if you have too much raw cruciferous vegetables, they're bad for your thyroid. That's neither here nor there. But I can eat a ton of that and not have any negative consequences whatsoever. So I'm really good at unfolding the proteins and breaking down to the sulforaphanes, the chemicals that you find in these cruciferous vegetables without any recourse, without having that type of gas. If an individual has that, does that mean there's something wrong? No. It could mean they actually ate too much for their body, their tolerance, their body's ability to process it. I would definitely consider a probiotic, which I think is one of our questions today, to recommend a probiotic, and I will do that today. One of the ones I just happen to like, and I'll mention it again so that everybody can get it, because it's very safe and innocuous and has all the species that various groups and governing bodies that even believe in probiotics believe in, because there's specific strains that have been studied in humans. And it's known as HMF intensive, HMF intensive, by a company known as Genestra. So I like that a lot as a baseline probiotic. And what I like that it is, it hits the math of the colony forming units that have been found in clinical trials to actually help normalize the gastrointestinal tract, make a positive in microbiota, and that would be 25 billion forming units, more than what you would see, right? A lot more than what you'd see over the counter. Some have like 1 billion. And I'm not throwing stones at those products, but I really like the data. And this was based on a randomized placebo-controlled trial of 155 human subjects that took the product for 21 days. And they ended up having more beneficial species in their microbiota than when they took a placebo. So that gives us a great piece of evidence. So they could have a lot of bad bacteria or an imbalance of good to bad bacteria, which we call dysbiosis. That could cause some of these effects. They could have a problem with their digestive enzyme output. That is something that could be evaluated as well. And there's great ways to do that. One of the best common ways is known as elastase-1. Elastase-1 is a DNA factor that measures how much pancreas output there is that is not affected in any way, shape, or form with even taking an over-the-counter digestive enzyme. And someone in your age group, Lexie, you'd want to see them in the 500s. And sometimes I'll see someone in your age group with a 320. And I go, oh, wow, this is not great. So we could start figuring out what's causing that kind of numbing of digestive output, the ability to start digesting fully and appropriately. And there's many different roads to that. We can go as deep as you want into that dialogue. Sometimes it's bad behavior. Sometimes it's overuse of alcohol or eating a food allergy, sensitivity, or intolerance. And then the last thing I would say is, then there's also the awesome elimination diet, which really doesn't cost anything.
Yep.
Right? You could truncate your quantity and look at other vegetables, because I want you to eat your vegetables. And you could see if just reducing the value helps. But I also want you to think, hey, you know what? Maybe I'm going to swap that out for a different total vegetable in and of itself. That's also in the same genus. It's also in the Brassica genus vegetable family, and see if that gives me any type of difference.
So if you were eating broccoli and it was giving you issues, what would you recommend trying to substitute?
I would try kale. I would go, then let's try kale, because it still has that awesome output. You're still getting the indole-3 carbinol that's converted to diindole methane in a perfect digestive environment that gives us these beautiful anti-cancer effects that we want from these vegetables, that there's just way too much of a database on that nobody will debate at this point in time, to see if that's the choice. I'm always going to, Lexie, I'm going to be honest, I'm going to fight like mad for that group. And I'm always going to try to find a substitute as deep as I have to go. You know, if I have to get down to watermelon radishes, which are really, you know, obscure and they're amazing, and best way to eat guacamole, if you want my opinion. Don't have chips, have watermelon radishes cut into little discs. They're phenomenal. You dust a little chili powder on them. Amazing. A little lime juice. And that helps with your digestion. That's staying in that family is so important to do, especially in the environment we live in. You're getting sulforaphanes and these important upregulators of our natural defenses and detoxification pathways.
Awesome. Kind of moving away from the vegetables now, swapping over to eggs. So people were wondering, is it more common to be intolerant to the egg yolk or the egg white?
I really love this question on so many levels. So I'm going to answer it just on several. First, when we're dealing with immunoglobulin reactions towards a food, which the primary main allergen marker is known as IgE, that is an immediate real allergy to a food. Then there's more obscure ones. There's something that I am a fan of, and I understand that it's controversial, but it helped me solve more cases than you could imagine. So it's difficult to call something controversial that changes lives in a beneficial way. If that's controversial, bring me into it. So it's known as an IgG4 subclass reaction, and that is drawn to what is most proteinaceous, so the protein component of a food. So in that one category, the egg white would win because it has 4 grams of protein compared to the egg yolk, which has 2 grams of protein. When you move out of that realm, and you move into the realm that Yale identified in 2017 that was strongly associated with irritable bowel syndrome. And they had basically an almost cure rate of like 87.3% on their analysis of individuals with irritable bowel syndrome. They found that you could react to basically any part of the food in a different way that's non-immunoglobulin. So
So
it's a
you could be
leukocyte swelling
reacting
reaction.
to the yolk and the white in two different ways, or it could just be
Yeah.
one or the other.
Yeah, and I've actually, and this is just so amazing and appropriate to my practice, because I actually just had an IgE to egg white in a patient and an ALCAT result to an egg yolk in a patient. And when we did it both at the same time, we got remission from their gastrointestinal complaints. When we just wanted to play devil's advocate and put the yolk back in, we actually had around 40% was what was reported to me of the same burden they were experiencing that they went to a long list of doctors to try to resolve. So that's why I'm a big fan of multifactorial reasons behind a reaction.
This one jumps into more of the gut bacteria. So people were asking
Yes.
about Candida and H. pylori. So can you just say what they are, how common they are, and is it really something to worry about?
Yeah, so Candida, and it's actually a great question. So Candida is a natural fungi that grows within us. We're supposed to have what's called a commensalism relationship with it. We really don't bother it in any way. It really should not be bothering us, and grows in our bodies probably shortly after coming out of the birth canal, or even after cesarean. We see that there's a growth of this species that will flourish. It's also misleading for me to not say there's many different types of Candida. Probably the most common that's in the intestines is albicans. There's tropicalis, there's monillus, which is the most common cause of yeast infections, vaginal yeast infections. So we don't want to confuse the two. So there's different species within the Candida realm of fungi, which is pretty fungi. So what's interesting though is while these species do grow, there's a kind of a whole bunch of books that came out, especially when I was coming up in the field. There was like the yeast connection, and basically yeast overgrowth or Candida overgrowth caused every problem under the sun. I think if Santa Claus didn't come, it was because there was yeast involved. It was really ridiculous. So when that happened, and I was in internal medicine, I was doing something pretty cool at the time. I actually was running a pregnancy test for the Candida albicans fungi to pass a threshold of dominance to show that it potentially could become an opportunistic infection. So there's a wrong-handed sugar that's only produced by Candida albicans that is known as D-arabinitol, and you don't make it. So if it's in human urine at a very high level, and there's different categories of diagnoses that are used, and we get this from like extreme cases of patients that are on chemotherapy or really tough intravenous antibiotics that will wipe out all good bacteria, and fungi will usually flourish in that environment, you will notice a high level of that. So when individuals are higher than like a 75, and it depends on the scale and what doctor measured, et cetera, and it's a simple urine test, I usually will deliver the news, very rarely. Congratulations, you're carrying twins of fungi, and we should go after that, and it should be treated medically, because it could be a host behind your problem. So
Is that typically with a course of antibiotics?
No, actually antifungals.
Right.
There's some great work on antifungals that can wipe it out. And believe it or not, there's a plant-based antifungal that grows in Australia. It is known as the horopito plant. It's pretty cool. It's red in nature, and what's neat is within a 5-foot circumference of the plant growing, you can't even grow mushrooms. It's so antifungal. Yeah, so it contains an antifungal component. So I have even used that in the past. It's pretty prominent by medical doctors in Australia and New Zealand. But classic antifungals like a day or 2 or 3 of diflucan, or Sporanox, which I'm not the biggest fan of because it's so powerful, and they usually use that more towards fingernail infections. That'll wipe it out. But please let me make this clear. That is so not common. Like, you have to be weak and pretty bludgeoned and pretty beaten down for that to be a problem. I'll also add that I have done thousands of DNA stool analyses on patients, and also looked at the records of microbiota measured from humans, because as you probably can imagine, this is a big topic in real serious medicine, not like holistic and out of the health food stores. Nothing wrong with that. I'm just saying, out of that, it's very well respected in modern medicine what the microbiota can do. So I do, when I run my full GI map stool analysis DNA wise, I will run 9 different fungi, and Candida, different types are there. Probably the most common I would run into on a rare occasion, but the common of the rares is Rotatorula. And that is one that's definitely associated with irritable bowel syndrome. And again, a 24-hour, 36-hour course of diflucan can wipe that out if the patient's not sensitive to that medication. But I want to make sure nobody thinks that this is a very common thing, because it's really not.
And could it be, if it's not a common thing, if they're experiencing digestive issues, it's more likely a different cause probably what they're eating?
Yeah, usually it's a different cause of what they're eating. And again, if you talk to a knowledgeable doctor, they can measure the right way. You want to make sure they're measuring the right way. I like a D-arabinitol, I think is really good. There's great data on it. There's peer-reviewed published literature on PubMed that shows why I'm coming to that conclusion. Also, we know very well from a common, now more common medical treatment called human fecal transplant therapy, where they actually will take a healthy donor's feces rich in specific probiotics and then implant that into someone else. That's the therapy. And I know it can be controversial, but it has been done in some cases. They screen that sample, of course, to see what's in there. And that's why I love the type of testing that's used in screening to get a very accurate piece of information of what's growing in individuals. I've had people with really bad diets on intensive courses of medication, and they don't have the species present. Having said that, I've had cases where I've caught it, and it was behind the whole problem. And they, doctors thought the patient was nuts until I showed really solid, excellent evidence for the doctor to say, wow, let's jump all over this. This is very helpful. And that's actually one of the problems that's transpiring.
And there was a follow-up question before we move on to H. pylori.
Right.
I already know the answer that you're going to say for this, but if you have Candida, do you think that a higher fat diet versus higher carbs will be more beneficial to heal the gut?
Yeah, and it's more than heal the gut. I guess you could say that, because one thing I should have mentioned about Candida is it becomes a problem when it's opportunistic. So if it's kept in check, it stays in this like circular state, spherical state. And when it leaves that, it can develop these what's known as dimorphic characteristics, and it can grow these like hyphae that can bore in to the intestinal lining to take root and to grow more, kind of like weeds in your garden. And when they die off, they can leave these tiny little portholes. But I should tell you, and everyone at home knows this, if Lexie and I are trying to bake bread in the kitchen and we put fat to try to get the yeast to grow and start to leaven before we bake it, we're not going to get anywhere, and we're going to have unleavened bread. And if I have fat subtracted and I add honey or maple syrup or sugar or a sugary starch to that yeast, it's actually going to make the bread rise, and it's going to give us a better bread. So sugars absolutely feed yeast. Does that mean if someone's eating, I'm not a big fan of sugar, as anyone who listens to me knows, but if you eat sugar, did you immediately get a yeast infection? No. If you have a yeast infection, is sugar a smart thing to do? No.
So focus on more fats, complex carbs, but proteins. For the most part, you should be okay. Most people are fine with Candida. So let's move over to H. pylori. What is that?
So H. pylori is a bacteria that, again, actually was something that was supposed to be not harmful in the gastrointestinal tract when it's in check. Ironically, if you have some H. pylori, some like normal levels, it can actually protect you from gastroesophageal reflux. How interesting is that? We all met some people, 5 people have a super spicy dinner, one of them gets heartburn. It could even be, it could be that they actually don't have any H. pylori growing in their gut. So let me make that clear, right? Just having the species doesn't mean it's the enemy. It's when it has a virulence and a larger level that it's a problem. So a virulence is a DNA genetic marker of the species, and there's multiple. Like you can have a virulence A, B, C, D of H. pylori, and that's where it leads to more types of pathology, like how it's been linked to ulcerations of the gastrointestinal lining. And doctors will use a medical treatment to make that go away, to knock down the levels of H. pylori. It's known as a Prevpac, is probably the most common one. And it's an antacid and an antibiotic. And they do that to reduce the acid burden, which is exacerbating the wound you have from the hole that was made in your gut. That's an ulceration through the muscularis. Through the mucosa towards the muscularis. And then they will give you an antibiotic to wipe out the species as best as they can. Nothing cures it 100%. It knocks it down to normal levels, which is what you want. But I'm more concerned when it's one flagged very high on a test for it, because you can be tested for H. pylori in multiple different ways. Doctors will do an endoscopy, they'll do stool analyses, they'll do breath tests, and they'll get accurate diagnoses to see if that's the case. I'm a big fan of DNA testing, so that's how I will know. So it's really the virulence that is the problem. But again, should you be concerned if you have the infection? Like a doctor said to the person who asked the question, I have H. pylori infection and it does have a virulence and it is causing my ulcers. Yes, you should. you should get medical treatment, because what's interesting is you can actually give H. pylori to your partner. And if you know, right, and just interacting with them in an intimate way could result in them getting this infection that could also lead to a very similar condition that you have. And that's rare, but I just, I'd be remiss if I didn't mention it, and it should be discussed. But there are a lot of cases of ulcers that are indeed caused by this species H. pylori and the virulence from growth. It can be measured, it can be treated, and typically patients will be normal with the species amount within 7 to 14 days. And if it's an ulcer, they will heal over a period of time.
So in general, for these two, some is normal and good, too much is bad.
Yeah, and then too much is bad, like many things in life, right?
Let's talk about digestive enzymes. So This question is, do you think digestive enzymes help with digestion and or food intolerances?
Well, I mean, I could answer this in a pretty decent way, where if you just have here's a great example. Let's use medical science first, right? As we always do, and lead with the most academic known intolerance. So scientific evidence has shown if an individual has lactose intolerance and you give them the enzyme lactase, they can improve and hopefully tolerate the lactose they're consuming and digest it artificially by giving a pill, which is a form of a digestive enzyme, and be virtually asymptomatic and have a decent life. What happens if they have a milk allergy? That's different. There is no cure for that except elimination, and maybe you could calm the immune system down and try a reintroduction like we do with peanut allergies, but it's not going to magically go away when you take a pill, at least at this moment in time. We'll see what comes out in the next decade, but at this moment in time, that is absolutely not the case. So enzymes can potentially be helpful. I'm sorry?
When we were having a conversation, you said, lactase, if you're taking one pill, who knows if that's your biological dose? What if you need 2? What if you need 3 and you're only taking 1?
Correct. And that's where it's PRN and as needed. So you do have to give the patient multiple doses of it. I'm not a fan of it. I think anybody who listens to me knows I'm not the biggest fan of dairy, and I could go on a diatribe on that, but I always have to stay diplomatic. Right? And you have to be diplomatic, and you can't have emotion when you approach the bench of science. So in those cases, you could work with a professional to find what is the dose for you so that you could tolerate your yogurt, if you're lactose intolerant, or what it is that you want to eat. Does that, for all intents and purposes, we do have clinical scientific data that can help if you find the right dose and everything that works for you. Does it work in general for all intolerances, meaning digestive enzymes? No. There's no specific set of enzymes for every little thing. Don't believe the hype about, gluten enzymes can help you if you're gluten intolerant and now you can eat gluten. It's really a placebo effect, in my humble opinion. When you swallow those proteinaceous enzymes, they're actually unfolded and broken down, and they're really not doing anything towards your gluten. And look, you're hearing this from a celiac disease patient, so I'm just telling you that. And if you think it's helping you, fantastic. If you have my disease, don't eat it. But if you think it's helping you, that's great. I don't see any data or scientific efficacy to verify that, so I do not recommend it. And I do believe in elimination of what you react to.
So food intolerances aside, let's say you're having a delicious meal of steak and potatoes and some broccoli, and you can tolerate it all well.
Yes.
Would taking a digestive enzyme to help just unfold things and break it down be beneficial?
It depends on, I'm going to give you a complicated answer. It depends on your pancreatic enzymes output and your own unique ability to digest. And that's divided into, let's just boil it down to 2 sources. One could make the argument that if you don't have enough ptyalin, one of the starch digesting enzyme in saliva, and you have dry mouth syndrome, or one of the diseases associated with that, like lupus, or on a medication that causes dry mouth, that you may have more starch that's not starting the unfolding process when it reaches the stomach. Fine, that's a complex situation. Let's leave that out of the mix for a moment, and let's just look at the stomach, and let's just look at the small intestine. So the stomach's going to be secreting gastrin and pepsin and pepsinogen that's going to help start unfold our proteins and really do nothing else. And there's some data on some lipase in the gut, but it doesn't matter. It just sits there as a raft, and it's not going to really do much until it gets into the small intestine. If you have a good output of hydrochloric acid, which is measurable, and you have a good output of pancreatic enzymes to digest, which is measurable. I mentioned one called pancreatic elastase 1. Enzymes are really not going to do much, and it's kind of like putting more gas in the tank that's already full, and it's going to start overflowing. If you have sublevels of pancreatic elastase 1, maybe someone's below 200 or they're in the 300s for an age group where it'd be better if they're in the 500s, enzymes have been clinically shown to help. Or perhaps you're hypochlorhydric, or worse, achlorhydric, which means you don't make any stomach acid. Whoa. Well, then that's when stomach digestive enzymes, specifically like HCl, which is hydrochloric acid, in a safe way, working with your doctor will absolutely help unfold the proteins, help you digest. But in those circumstances, what happens if you give HCl to an individual that has enough of their own HCl? Wow. You basically are putting gasoline on a fire, and there's a chance for heartburn. There's a chance for potentially lowering the pH even further, maybe stimulating some irritation of the gastrointestinal lining, the stomach lining, known as gastritis. Definitely, if you have heartburn, you'll have the worst heartburn of your life if you make enough hydrochloric acid and then you take hydrochloric acid and then you have heartburn. Wow. And trust me, I've gotten these calls by people that said, I know you told me not to do it, but I saw on a TV show and I ran out and I took it, and here's where I'm at. And you have them gargling glutamine and calling their doctors, and I'm on a 3-way call trying to solve this problem. So yeah, it really depends on the purpose. I do not think it is something you should run out and do. Now, could you take like a plant-based digestive enzyme or digestive enzyme that's basically more alkalinized, so it's not hydrochloric acid, and would that be safe to experiment? It would. So if you have maldigestion and you've done an elimination diet and you don't know your pancreatic elastase 1, taking a pancreatic enzyme without HCl, could that be a safe experiment? It absolutely could. And I could even tell you a place to start that's very safe, and that's a lot of doctors recommend because it removes as much hypoallergenicity as possible. And there's a brand called Pure Encapsulations, and they're very hypoallergenic, and they make a product literally just called digestive enzymes, and they're super, super small. And the reason I'm mentioning them is I've used them in clinical practice when I have a 25-year-old that has a pancreatic elastase 1 of like 100. And there's usually a secondary cost of that, by the way. So I'm using that as a temporary solution until I can fix the problem. Real food allergies stun your ability to digest appropriately and can drop your pancreatic elastase 1. Celiac disease stuns the gastrointestinal tract immunologically, stimulates and upregulates cytokines, which paralyze the pancreas's ability to produce enough digestive enzymes and truncate their function. So they're great temporary solutions while I'm just trying to find the cause. But if you have a problem making enzymes, there's something deeper there, and you definitely want to speak to your physician.
Staying on the topic of the stomach, this question is, my boyfriend wakes up gassy, like burping all the time, facepalm emoji. He says that it's just him. Thoughts?
Yeah, and that's a great cop-out that he just, he's just saying it's just.
This is how I am.
Yeah, no, look, everybody has gas. There's something like, 50, somebody actually calculated this, and God bless the person that did their PhD in this field, because I know they're out there, and I hope they're listening and they write into us. But we pass gas as human beings, and normal is like got a specific range under 50, up to 50 a day of like burps and flatulence and et cetera. I've always felt that was just a little too much.
Me too.
Right. Yeah. When you, because I think it's just a scale. It's really, to me, not just the most normal thing. And in the stories you tell, which I know are still accurate, is when you went on your elimination diet, you drastically reduced your gas. And I'm literally, as I'm talking to you, Lexie, I'm trying to think the last time I was gassy. I'm like honestly trying to think, like, if you're chugging a carbonated beverage, there's a reason. If there's no associated reason with it, and there are potentially some type of symptoms, and when you talk to the person, Lexie, something comes out. So I've had cases like this brought to me by spouses, and guess what comes out after like an hour of talking? I was B12 deficient, and my doctor did this. And I'm looking at this healthy young man going, and you needed B12 shots? You look like you could run through a wall. clearly there's something wrong in how you're absorbing. Could this expression of belching and flatulence or whatever be the side effect that's telling us something's going on? And that's how it's giving you the sign. But something else, or I'm deficient in iron, I'm deficient in vitamin D. That's not normal. Unless you have a disordered pattern of eating that completely avoids the food that has the substance, then clearly there's something more going on. So I would say if there's no symptoms whatsoever and the guy's the glowing health, picture of health, then I would say we leave him alone and tweak his diet a bit. Trying to look at gassy foods as we were talking about here, and cruciferous vegetables, and changing different ones, perhaps an elimination diet. But if there's something going on where there are some symptoms that are not being alluded to in this question, why not, start exploring SIBO or food intolerances and see if there's an associated symptom.
Yeah, like I used to burp and fart all the time. Like it was just, I thought, just like this person's boyfriend, I thought that was just me. That's how I was raised, because my entire family was like that. I was like, oh, it's just genetics. But we all had the same genetic food intolerances that none of us were aware of that got passed down that were causing those issues. And now that I eat a clean diet with no gluten and no dairy that I react to, I don't have gas, like period. Just like you, I can't remember the last time I did.
No, it's a really remarkable thing. And, going deeper than that, I have a real great friend. I love him. And I think he's a brilliant man. And his name's Dr. Loren Cordain. And he basically picked up the work of Boyd Eaton that came out in 1984, published in the New England Journal of Medicine.
There you go. 10 years before I was born.
Yeah, exactly. So in 84, it was Boyd and Eaton and Connor and Dr. Connor, and can you imagine that, the New England Journal of Medicine, and they were publishing that. Wow, I'm wondering how much we could change health-wise in the population if more people just ate based on how they evolved, the genetic component to that, and that's where the hereditary of an allergy and handing it down, and me having celiac disease and my daughter having these genes and my daughter having had any gluten at all, and all the stories of how pediatric cases you read, like, this is normal. My daughter's had none of that, right? This is the loose stool period, and nope, never. So that's so important to people to understand. So that's why I don't like, and I kind of debate, well, it's normal to burp, and pass gas 50 times a day. When did we develop that scale? Who was counting those?
Were they tested for intolerances?
And much like the warning on spray paint, I hope it wasn't transpiring in a sealed room without proper ventilation. If I could just add there, right? So, warning for this study. Seriously, no, I
tattooed on me as a child.
Yes, right. So I don't want to push, my work or the work that I believe in on everyone, but I do believe that is not normal, and it should be explored. But I'm trying to be really kind and diplomatic.
Investigate. It could be normal, but also could not be.
Yeah.
So next question is, what is Inulin? Is it a prebiotic?
Yeah, so Inulin, and this is a great question. The main source of Inulin is chicory. It is a complex sugar that's in the roots of various plants. And the most dominant source is chicory. And it's a really interesting form of polysaccharide that kind of resembles fructose. And it has these beta linkages, I believe they're on 2 and 1, that prevent it completely from being unfolded by digestive enzymes. In English, it's this real complex polysaccharide that is not in the same family as like a sweet potato. And it is designed in a way that it can't be cleaved, digested, or broken down. And it acts as a prebiotic. Many people are sensitive to inulin. It is used in abundance in packaged foods. I happen to be one of those sensitive people. We've never discussed this on this program. And you may say, hey, wait a minute, Dr. Pastore's eating all these processed foods. No, I got a great story for you. I was in a restaurant in New York City, and it was a really nice, classy, organic restaurant. And I really wanted a nice organic coffee, and I got one. And I had a bad experience. And then I went back and asked them for their ingredient list of iced coffee, thinking it would just be organic iced coffee. And the second ingredient was inulin from chicory. So much like fructooligosaccharides, known as FOS, inulin and FOS may not be your friend, and they can cause gas and bloating because they cannot be digested. In small quantities, the way they're found in nature, because I don't eat chicory root, but the way they're found in various plants, the amount of inulin that I would get in very, 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 very small micrograms and less, nanograms, they function as a prebiotic, feeding good bacteria, One of the things they do, prebiotics, is they can help very important probiotics. There's one known as Anchormansia. That's a great way to win a Scrabble game. It's the only word I'm aware of with a double K. But Anchormansia is awesome at growing the mucosal lining, particularly for people with celiac disease, where that starts to become a problem and plays a line with the separation of the intestinal tight junction cells. So prebiotics, particularly those from cranberries, play a role in helping those grow. But yeah, so I hope I answered clearly what inulin was.
So some people may react to it, and if you do, get your fiber from elsewhere.
Yeah, you know, or just stick with the fruit, the normal vegetable sources of fiber where it's from, because some people really react to supplemental fibers and other people don't. I prescribe them for people where I think it's beneficial, but for many people they may be sensitive like me, and it's just not in our game plan. And I eat more than enough fiber from vegetable sources.
So you had mentioned fructose and how inulin is similar to that. This individual has a fructose intolerance. So she says, I can't eat fruits or vegetables and also most starches, so I'm not good with rice or oats. Aside from being more hungry with not so voluminous foods, do you feel there's a hindrance in muscle development, or does it really matter where the carbs come from?
Yeah, this is a great question. So first, just for anyone who's listening who's interested, other than just the individual that spoke, this sounds like a hereditary fructose intolerance disorder, and that means that they would actually have some type of polymorphisms on variants of what's known as ALDOB, which is the specific gene which plays a role in our ability to actually process fructose. What also happens in fructose intolerance, even if there's no genetic abnormality for the specific disorder, but just as purely intolerant disorder where the person doesn't tolerate it so well, is receptors for fructose don't work that well throughout the gastrointestinal tract, and way too much fructose stays inside the small intestine than it should, resulting in a massive burden in gastrointestinal complaints and symptoms. It's really serious. People can think they even have inflammatory bowel disease when they have this type of problem. So I really feel bad for this individual, and I'm very sorry. Having said that, I do think it's pretty neat by default that they can't process grains at the same time. I would definitely want to make sure that the individual ruled out celiac disease. I would start with the genetic test for it, because it does trigger some of these other problems that she seems to, or he seems to be experiencing. And we did a whole podcast on that, and they could look at DQ2.5 and DQ8s. That's a great place to start. By the way, that means HLA DQ2.5 and HLA DQ8. Those are the two main family parents of celiac disease-based genes. And the reason I'm saying that is, obviously, I'm not going to tell the person to go on a gluten-loading diet, but at least we will know if they have risk, and then that individual will be able to have a really good, frank conversation with their doctor. Should I pursue this? Because perhaps that's the treatment that would allow them to eat some of the other foods. If they're not consuming gluten at all for an extended period of time, and they're absolutely certain about that, then it probably is this true fructose intolerance. And it happens. And in cases like that, where there's a crossover to grains, guess what? I have a ton of multi-million-dollar professional, I say ton by weight, a ton of multi-million-dollar professional athletes that are not consuming any grains whatsoever. They're following a more hunter-gatherer diet. They're getting extremely rich sources of carbohydrate from those plants. If you're saying you can't even digest a sweet potato,
this is her case. I know her personally. She can't digest sweet potato.
Yeah, that's definitely a high risk problem, because the risk you have there. And I would, if this was a case I was working on, I would be militant at looking at fasting glucose. I would literally have the person monitor themselves. Insulin, making sure there's absolutely no risk for hyperglycemia, measuring their triglycerides, looking at their fractionated cholesterol. Because what happens in these cases, Lexie, is these patients will go after more simple carbohydrates to meet a macronutrient requirement. And they can end up having an exaggerated, in part by genetics, response to these carbohydrate sources, resulting in another secondary problem that we want to avoid. So believe it or not, it won't hinder their muscular development if you switch their macronutrient percentage ratio more towards a protein dominant, fat dominant diet. This is a very extreme case. And if you even question that, shout out to someone I know and I was on his podcast, but just look at a photo of Sean Baker and tell me if you think he's not growing muscle at 53. So I'm just saying that it's okay if you're not having amount of carbohydrates that you may feel you need to grow, because you will be able to grow. You're actually more at risk for having a secondary type reaction to a high intake of high glycemic index carbohydrates. So if you can't find those carbs that are right for your body, and you really dug deep, I would exhaust all avenues for diagnoses to make sure. Also, last thing, please make sure that you don't have a true intolerance to a food, or even a true allergy that could be causing a lot of these problems, or at the minimum, open up a doorway to allow you to eat other foods that you may need to hit your maximum muscle growth potential.
Awesome. So this individual, I know who you are, you know who I'm talking about. Feel free to reach out to me post podcast and listening to this, and we can have a further conversation on that.
Awesome.
Moving on to a different topic of intermittent fasting. And
Yes.
Intermittent fasting increase bloating?
It can, and there's several reasons why, and it's neat. And everyone should listen to my interview of Dr. Grant Tinsley, a really wonderful friend and just probably the best mind in this space, in my humble opinion. Shout out to him. His last paper had the highest rate of downloads of any paper on the topic of fasting in the history of the journal it was published in. So everyone should go seek out Dr. Grant Tinsley and listen to that podcast. Here's why. Number one, the number one thing I see for bloating during intermittent fasting, the patient doesn't realize it, is they're dehydrated. They have inadequate hydration, which actually causes a bloating effect. Our bodies want to hold on to water when we're not getting enough of it. How interesting is that? So we retain more water in a presence of dehydration, and that is the number one job after elimination. Once the colon's done with elimination, it's recycling our water supply. So you really want to make sure that the individual is getting enough water. And if they say they're getting enough water, add more water, and you can usually cure the bloating that transpires during intermittent fasting. Also, it's very important to understand that how is the individual eating when they're having their cycled time?
Are they having 2,000 calories of junk or 2,000 calories of good food?
And I can't even tell how many of these patients are like hyponatremic and they're crushing sodium at the same time. And that opens up these chloride ion channels and it rushes fluid into interstitial fluid from between cells into the gastrointestinal tract, and also to digest that enormous amount of calories during that window. Some people are like eating over a 4-hour or less span of time. And that may be a sign that it's, as you'll hear from my interview with Dr. Tinsley, it may not be right for them. And they may need to do different types of things. Perhaps calorie control is better for them, or there's not one path to Mecca, right? So there's all these different paths. And I love the doctors who say that, man, and Dr. Tinsley's certainly one of those. But it's so important to be able to evaluate what you're eating when you're eating. Junk is going to be a disaster. Too much sodium could be a disaster. That's when you may sit down to, if you're blessed to have a great cook like my wife, and you have this massive broccoli salad during your window, that's not a great idea to have 4 cups of broccoli with, your porterhouse or whatever you're doing. Not the best idea. Or maybe you had, the equivalent of 12 hard-boiled eggs of egg whites. Wow. I would not give that to the person with the emoji slap face with the gassy guy. That's just, don't let him intermittent fast and hammer eggs, okay? So, and broccoli. Yeah, so those are the main reasons. And then lastly, if it's a woman, it's definitely, there could be some hormonal changes that could cause bloating during intermittent fasting. Sometimes when you're in a fasting state, there could be this increase in norepinephrine, which people really like in the weight loss field of science and research. Probably the best was in 2001, published in the journal, the American Journal of Clinical Nutrition. The doctor's name was Dr. DeLue. And he was looking at norepinephrine increasing and how norepinephrine was associated with an increase in fat burning. Well, while that's great, there can be a hormonal change during menstruation that can result in an increase in norepinephrine, but the hormonal change is actually driving bloating, and it's causing you to store water. And those are the main ones. And I promise I could go on a longer diatribe if there was endometriosis and there was combined with intermittent fasting, et cetera, et cetera. But those are the main ones, and I bet you that would wipe out the bulk of the people who that question is appropriate for.
So I'm going to pull one of our later questions because it ties in really well with
Please.
The hormone changes of a women's menstrual cycle. Could menopause also cause bloating?
Yes, without a doubt. Menopause and the changes in hormones could actually slow down gastric emptying time, which can cause this kind of backup effect and result in a bloating and distension. It's elongating transit time, and there's an adaptation period that you must go through. That time can also change the flora, in my humble opinion, the good bacteria, the microbiota, which can result in, of course, then some moments of gas and bloating. And that typically would change over a period of 30 days from the onset of menopause or change in periods. So yeah, there's definitely an association hormonally with transit time and the time of the month in the cycle and the cessation therein.
So for women that are going through menopause, it should be like a 1 month thing. It's not 5 or 6 or 7 months long. That's an underlying cause.
That's an underlying cause, and we really want to dig deep, and we want to start examining the fiber intake that's in the diet, and is the right fiber that's in there for the diet. And also with menopause time, I want to start looking at pancreatic elastase 1. I want to look at digestive enzyme output. I want to look at what's going on in the gastrointestinal tract and make sure that everything's going appropriate. And that's also probably the biggest time for Firmaticutes and Bacteroidetes, which are two different species that fight in flux, that actually dictate on all the new modern literature how much calories we actually absorb from a food that says how many calories are in it. And it's actually matters. It matters. There's studies now we're looking at where you can absorb 300 more calories from a meal if you have the wrong species of bacteria growing dominantly. So that's pretty big when you're calculating macronutrients. And especially if you're subtracting like 300 to 500 from someone, it has a big effect.
And as a coach, when we try to put someone in a deficit, we use calculations as best as we can to determine a safe deficit. And if they're coming back and we're not seeing those changes, it's like, well, are you not working hard enough? Are you not eating what you're supposed to? There's a lot of underlying issues.
There's a lot of underlying issues, and those are always the number one issue, right? There's nothing more misrepresented than a food frequency questionnaire. And that's why when I work, I mix it up in so many different ways. I actually had a patient say to me last week when it came to the nutritional component that they felt like a spotlight was on them, and it was like an episode of like LA Law, or I was like, boom, boom, or one of those legal shows. And I'm like just grilling them because it's amazing what does end up coming out and does end up being reported. And it's such a challenge in the nutritional sciences. Then you throw on top of that all these other problems that could transpire, and it does drastically change how an individual is processing and absorbing what they're eating. And they should listen to our calorie in, calorie out, whichever the podcast we did on calories. So pertinent at this juncture. Someone should hit pause on this one and go play that one and then pick this one back up.
Moving on to more of the diagnosis and conversations with your physician. So we had one woman comment saying, my allergist showed me some evidence on why the IgE test was not accurate unless you were looking for something specific. What are your thoughts on that?
I'm going to answer this question as someone who's interpreting it two different ways. So I'm going to interpret it to myself, the way I'm going to process this question is if the individual is saying the following. A total IgE test basically would not correlate to any value if I'm not being tested for a group of something in my environment, internal, or external.
I think I have an intolerance to eggs. We should test for eggs. Or I think I have an intolerance to milk. We should test for milk.
Yeah. Well, then, yeah. And, or then the other way I was interpreting it is here's a panel of 90 foods. And the doctor said, this is not accurate, even though it's the number one accepted immunoglobulin reaction by the American Academy of Allergy. Okay. Here's my answer to all of that. There's values both ways. And this is unbelievably timely and appropriate. I have such a vast practice and had such a big one in the past. And really now it's incredible how it's like these very unique cases that I actually have my very first of something. And I never really could even say that to you, Lexie, because at this point in my life, I've always said, well, I've seen that before and I've had that twice, even if it's crazy rare. I actually had my first IgE, immunoglobulin insufficiency. That's a big deal. And that's when you start looking at all immunoglobulins, right? And you want to make sure that everything's okay there. And I won't get in depth in that because that's off topic. But much like our conversation that is on topic, and I'll stick to just the topic part regarding foods and allergies. Imagine the celiac disease patient has a secretory immunoglobulin IgA deficiency, IgA deficiency. And then they go in and say, doctor, I think I might have celiac disease. And the doctor says, fantastic. The medical appropriate path to take is I'm going to measure a tissue transglutaminase IgA antibody to see if you have any type of immunological reaction in your intestinal lining to gluten. Obviously, that's a wrong path because the individual is SIgA deficient. So they want to verify that right out of the gate. If I find a patient who's IgE deficient, I can't even test them for an IgE against anything. So I'm really proud to say for my entire career, when I'm looking for allergies, and I look everywhere, and intolerances and sensitivities and all the newest ways by Yale, etc., I always start with a full panel that includes an IgE, and I get a total immunoglobulin IgE, so I know what the person's status is and are they normal. They should be less than 87, but not less than 2. They should be less than 87, but not less than 2. So let's say
total IgE 2 to 87.
Yeah. So let's just say they have, I don't know, like a 57. I go, fantastic. They're right in that range. Then at the same time, I measured on them because I don't wait unless, they were IgE deficient. I measure a full panel towards immediate foods. And if I'm working on a case, that's also their environment, looking for that. I'm happy to say one of our listeners, who's an older woman, heard the podcast we did on food intolerances and allergies and sensitivities, and actually said, I have all this mucus and phlegm and coughing and I can't sleep and it keeps me up, and went to their doctor and said, I think I might have an allergy. And the doctor ordered what I just said. I don't know the doctor. I want to hug the doctor. The doctor ordered a total IgE and then a panel of about, 45 foods. And the patient showed up being really allergic and IgE positive to shellfish and to cow's milk. So what do you think the doctor said? This is really cool. The doctor said, hey, I would like you to eliminate these foods for a month and then come back to see me. And in 1 month, this individual had a complete elimination of her mucus and was able to sleep better and didn't have that coughing, weird sensation post-nasal drip. And why? Because the patient actually was lucky to be one of the limited people, re-listen to that podcast, you can see the demographics are really low, that had a real academic, true allergy, an IgE. So the value in an IgE is awesome. I don't understand the part of the question where the doctor is saying, you have to know what you're looking for. That's like kind of saying, I have a migraine and I know it's caused by the weather. The problem here is just relying, having the doctor rely on the patient to tell them, I want to be tested for food X, I feel is just not logical. And you really want a full battery. If you could say, I think I'm allergic to tree nuts, the doctor should test for all tree nuts and other things, right? The doctor should say, well, how do you know you're allergic to tree nuts? Well, when I eat walnuts or when I eat almonds, I notice an itchiness in my tongue and it gives me rashes and my throat gets itchy and I feel like it's going to close, but it doesn't. And that's an anaphylactoid type reaction, and not to be confused with anaphylaxis. And it could make someone nervous, and the doctor should run a whole battery of tests because it's just so much more logical, and also look for everything that they can within reason to see if the patient has a true IgE allergy.
Because
so
if you're thinking, let's say you're reacting to peanut butter and you're thinking, okay, it's tree nuts, it could be something else in that peanut butter.
Yeah, and peanut butter, as we know, it's more in the legume pulse family, right? So there's a great chance that they're missing out. But what I also love is like this, it's not a common thing to have an IgE-based allergy. And we know that from the American Academy of Allergy, was like 1% to 3% of the population. So it's just so important to just look to see if it's there. I do it on every case, and when I find it, it's so amazing. I had a patient that didn't even realize they had an almond allergy, and I was able to tell them that. And when they give it up, there's a cause and effect. So if this doctor said, or some doctors say, I disagree because you have to lead the patient, I would also say, what else are you treating the patient for? Like I can't even tell you how many IgEs or different immunological reactions I found to foods that were the whole cause behind the anemia, the whole cause behind the vitamin D deficiency. Then why are you not thinking of that? The patient doesn't have a dying need for a pill of iron. They should be absorbing all of that in their diet. And this is where food allergies can truncate digestion. And it goes back to the beginning of the conversation that it's so important to understand your immunological relationship to what you eat.
So Get a new allergist.
Get a new allergist. I think this allergist should be fired. And I'm sorry. It's how I feel. I think it's so important to understand all allergies. And when I talk to doctors that are more open-minded, they're like, oh my God, I don't even do an IgE because hardly anybody's positive. I say, fantastic. At least you'll know. Because I have been seeing them, and I go through streaks where no one's positive, but when you get them, it's awesome. It's awesome. You're completely like this woman. And by the way, this woman became my patient, and I'm seeing her tomorrow morning. And it's amazing how when you find those cases, it's just life-changing.
So get tested still, get that IgE run. But if they say, what specific foods do you want to run? Go find some.
Run the panel. Yeah, run an IgE panel and get a total IgE with it. It's really that easy. They should be together.
Another one that we got was thoughts on enemas to heal the gut. Would they clean tight junction cells to promote healing or irritate it more?
They'll actually do worse. And of course, this is not, if it's something's medically recommended by your doctor, do that. But I'm answering a general question based on my knowledge base and my practice and what I know in academic science. Enemas, colonics used for no medical reason definitely are associated with washing out good bacteria and giving you a chance to get more of the opportunistic species to thrive when they're done habitually. The tight junction cells are way far away in the small intestine, and they're not in the colon where you do an enema. So they're not even reaching their target audience. Neither is a colonic. So what's transpiring, and if it does, we have a real problem, because then you have an issue with your ileocecal valve, and you don't want colonic stuff getting in the small intestine. That's why there's doorways, right? I don't want my colon stuff in my esophagus. That's why we have a lower esophageal sphincter, and then a pyloric sphincter from the pyloric region of the stomach into the small intestine to the duodenum, and then the ileocecal valve from the last part of the small intestine known as the ileum into the cecum, which starts the colon, etc. There's doors for reasons, people. So no, don't do that. Thinking it's a healthy thing. It's deleterious. So just to repeat that, probiotics have to adhere. They have to really work well, and they don't do it very well. And that's why when you look at the data, we see around 20 billion colony-forming units. In my humble opinion, is 25 is really a great starting point for a regular person. Of course, talk to your doctor about that, and I always choose the safest things you can. Sometimes if someone says, well, I just want to use one species, you can't beat the clinical trials on the dairy-free version of Culturelle, which is Lactobacillus GG. Yeah, don't get the dairy one. I've had patients.
There were, in my gut health talk, when I was bringing that up, I was like, go check your probiotics for skim milk. And I had so many people either message me during that conversation or after, being like, I had no idea mine had skim milk in it. Yeah.
Oh, man. No, that's crazy. And it's why I love HMF, a product called HMF Intensive. And it's the ingredients are literally lactobacillus. There's 2 different strains for 18 billion. There's bifidobacterium, there's bifidum lactis, there's bifidum anamillus, all the strains that have been studied. And then there's microcrystalline hypomellose, which is found in, plant fibers, period. There's no other ingredients. There's no dairy. It's hypoallergenic, and it's what I use from teenagers on. For infants, I use something completely different. I use probiotics by a company called Claire, and just based on specific cases and based on the species they need. And I determine that by doing a DNA map. But for all intents and purposes, the general population, I'm really comfortable with what I just mentioned. And then just to clarify, if someone said, well, I only want one species, my doctor said, choose one. Lactobacillus GG has a real strong list of studies, but they have 2 versions, one that's dairy containing and one that's dairy free. Definitely try the dairy free one. And it's made by 2 great doctors, last name's G, which is where they came up with the nomenclature for the strain GG. And it's strongly associated with helping with irritable bowel syndrome, et cetera. But I like a blanket approach.
So ideally minimum of 15 billion with a couple.
Oh yeah, I mean, that's 25 is where the clinical trials really start showing adherence and a positive change to the microbiota. But I've had patients that really want to try something very slow. And I say, absolutely, try one of the single strains that are well researched and studied. And you can't go wrong at between 500 million and 1 billion. But if you really want to see a change in a month, right, definitely try HMF Intensive. I'm not paid by the brand. I didn't make the product. I wish they knew I made the product. I'm teasing. Maybe they would sponsor the podcast. I'm so kidding. But no, I just really love them. I've taken it for years personally. I think they're amazing. Another product that I've taken over the years, and I met him in his lectures, and he signed his book to me. He actually wrote a textbook on probiotics, is a doctor in Japan named Dr. Ohira. And I'm so happy to see that his probiotic company is thriving. And you may say, well, why isn't that your first choice? Because now we're in a world of really identifying food-based mediated reactions that are so vast. And I had to stop because there's so many food-based ingredients in this wonderful product that I found patients react to some of the ingredients. So even it's in small amounts, that Yale research study on DNA supernatants and these different types of leukocytic swelling reactions was just massively eye-opening. And something as simple as being a sleuth to the tiniest ingredient sources have helped my patients change. I just recently solved a couple of cases on stevia reactions based on what Yale identified. Agave reactions was another one. And then one of my personal favorites, of severe leukocytic swelling to aspartame. And the patient felt like just unbelievable. And all their symptoms were with all these Diet Cokes and all these protein shakes and going super low carb, but pummeling these artificial sweeteners that Lexie and I talk about on an entire podcast. And imagine having all that artificial sweeteners that we already know are not the best thing for you and they're alien molecules, and then combine that with the individual actually having an immune system reaction to the substance itself. That is a double whammy. And it hurts more than lactose intolerance, I kid you not.
I think it's also important to mention with the probiotics that when you do start to introduce them, there is going to be a digestive adaptation period, like anything else, where it's going to take a while for you to feel normal.
Yeah, doctors always ask, give it 30 days, and I love this doctor. I'm going to mention him by names. I just love him because I know him for so many years and we have a mutual love, and he's written some really lovely letters about me and me about him. There's a brilliant medical doctor in New York City named Dr. Alan Raymond. I love him. He's a super smart gastroenterologist that's a firm believer in the microbiota and what you can do with probiotics. And there's so often he will diagnose SIBO, small intestinal bacterial overgrowth, that I mentioned on the top of this talk, cure irritable bowel syndrome by measuring, identifying, and then putting the patient on really powerful probiotics for them. And he'll use prescription strength and stronger than doses that I'm using now. And just for the listening audience, I use really high doses when I identify a need. I'll use 500 billion in clinical practice for a period of 2 weeks. And it literally looks like a Z-pack. And the patient's taking a blister pack and they stop when it's empty. And I'm doing that because I need to just really put in the good guys and changing of the guard of the good bacteria versus the old bacteria, the bad guys in there. And it takes a period of time. And to quote my dear friend, Alan Raymond, let's give this 30 days. We're changing the guard and we want to have some good bacteria take root.
So be patient with that. And I think I saved this question for last because it's a very good, just wrap everything together. And that is, how can you create an optimal environment for gut health?
Yeah, to create an optimal environment for gut health, you want to really eat a super healthy diet, a really clean diet. The least amount of alien molecules you consume, the better. The least of exposure to things that kill good bacteria, like excess alcohol consumption. Perhaps maybe you're not a fan of eating organic and you eat a lot of pesticide-laden produce. There's some data that could be problematic in high amounts. And I'm a big fan of eating as clean as you possibly can and healthy for your body and understanding your food intolerances, making sure you're getting adequate fiber for you has, from the sources that work for you, along with a probiotic, has been shown to really enhance your gut health. And I know that sounds funny, but that's basically what happened to me. Getting my disease diagnosed, removing my then allergy, dairy and gluten, right? Just doing those two things, along with a probiotic and healing my gut and eating clean, really just helped me feel really good. And then that gave me, Lexie, after being like, oh my God, the tiniest thing would knock me over, then it gave me the ability to have some flexibility. It gave me the ability to have some flexibility where I can feel healthy and I just don't feel sick and I don't have the gas. And that's really the sign of a healed gut. And of course, I'm blessed enough where I test myself and I can look at those markers and go, wow, that is awesome, So, just taking care of yourself the right way for you and building that foundation of health, then you're able to have some freedoms. And I love the patients who will come to me. I had a patient recently and said, I want some freedoms. I've been militant and I did all these things that are awesome. I want to have that glass of wine with my wife and I think it's going to kill me. And I go, it's not. It's not. What's going to kill you is your mental reasoning around that. Now, if you have an intestinal disease and you need to rectify that and have that treated right away, and there's no reason you can't do that, first fix all those problems, eat super healthy, and you will tap into that. I'm more of a 90-10 rule guy, but you'll tap into that 80-20, 90-10, whatever works for your body. But because I don't think anybody wants to be, 100% militant all of the time, except when it comes to your allergies and your disease, which is what I do.
Yeah, life is all about balance and enjoying things in moderation.
Yeah.
I'm intolerant to gluten and dairy. I'll still eat it every couple of months if there is a special occasion or there's a treat that I really want to enjoy. I accept responsibility for all the damage I'm doing in my body. I mentally prepare myself because I know in the days after eating that, I'm going to feel awful. My mood is going to be way worse. I'm going to be fatigued. I'm going to feel tired, and I'm going to continue to have those food cravings, all just from the digestive stress of eating it that one time does. But sometimes it's worth it.
Yeah, and that's great that you don't have that, right? That disease, and I'm blessed where I don't have to share my indiscretion that I love. When I do something big, and it's a way I celebrate. When I published my last paper, I had one heck of a martini. It makes me feel, proud, and it's a celebratory thing. And guess what? It doesn't bother me in the slightest. And I'm very well aware of people that have the smallest amount and it makes them sick. And that's a different scenario. And I test people genetically, et cetera, et cetera. So it's those types of moments, those things in moderation. And by the way, I think some of that dialogue's on the Loren Cordain podcast, where even the great Loren Cordain talks about his wine. And that's a very important thing to know. And it's awesome to have some of that balance, right? And I think it's a great part of life. But the problem is the majority of the population are not doing the most important part.
They're doing the 20-80 instead of the 80-20.
Yeah, and that's where we really have a problem. And of course, as we say over and over and over again, and let me make this really clear, when you're talking about a real serious diagnosis like celiac disease or an allergy, of course, an anaphylactic allergy, but just an allergy that's making you sick, it's so important to not even have any leeway there.
Never.
Right? That's
mindfulness. Never.
Yeah, never. That's where you can't find. So sorry I'm going to say this, but I'll give you a little PhD secret. We all talk, and MD secret when I'm talking with my colleagues. Pick your poison, the one that's the safest, and then that'll be that's in your 20 or 10, whatever realm you fit into. And yes, I have colleagues that claim they're in 5, and I call BS on those guys who'd say they're 95.5. And I know you're listening right now, but that's not the case. So yeah, I think that really helps if you have that balance, but you're also really first solving the problem.
So I want to say thank you for answering all of my team's questions. I know that they will absolutely appreciate it. And I'm super happy that we got to turn this into a podcast too, because if they had the questions, then, listeners probably do as well. But we're going to wrap it up here for this week. So we will see you next time on the Pastore podcast. If you have any questions, you can find more information on a lot of these topics, either through our previous podcasts or on Dr. Pastore's website, which is drrobertpastore.com. He's on social. You can DM him if you have specific questions at Dr. Robert Pastore. He responds to all of them when he has time. He's a very busy man. But that is it for us right now, and we hope to see you back here next week.
Thank you so much. It was an honor to answer these questions. Thank you to your team, and thank you everyone for listening.